Okay, so good morning, everyone, and welcome to today's online event. We're really pleased to have you with us, and we're looking forward to a productive, engaging session. Before we begin, I'm just going to run through a few housekeeping points to ensure that everything goes as smoothly as possible. So please note that this meeting is recorded, and both attendees and speakers may appear on screen during sessions. If you're uncomfortable with that, please keep your camera off, although we actively encourage you to keep your camera on where possible, particularly during our theme discussions, as it really helps create a more inclusive and engaging atmosphere. Please keep your microphones muted unless you're speaking to avoid background noise or disruption. You can add captions if you wish, but please be aware that there might be errors in these. Please raise your hand if you'd like to speak, and make sure to unmute your microphone, which you can find in the lower left-hand corner of your screen if you're not familiar with Zoom. And please note that we have a tight schedule, so we may not get to answer all questions before we move to the next session, but we'll make sure that we'll write down your question if it's not answered, and someone will get back to you. And we also encourage, during presentations, if you think of something, please use the chat function, which you can find in the bottom of your screen. It's the fourth one down. And you're more than welcome to ask your questions in the chat, and someone will try to respond to that during the Q&A sessions. And you may also notice ARC staff posting useful links to websites or documents in the chat during presentations. To avoid losing your place, we suggest copying and pasting these to check later, rather than opening them immediately. And if you miss anything, please feel free to just contact us via the event email address. We ask all speakers to stick closely to their allocated time slots to help the day run to schedule. And I will give a polite reminder if we start to run over. We're going to have a 15-minute comfort break partway through the day, and we'll let you know when that's coming up. It's in the schedule if you want to have a look. And it's possible, but extremely unlikely, of Zoom sessions being disrupted by unauthorized guests. If that happens, the session will stop. Thanks, Mark. And now I will pass over to Ben and Matthew Brown.
Hi, everyone, and thanks, Heather. So we're going to talk a little bit about the Preston community wealth building model and research that we completed on that. So I'll just give a bit of an overview of the research and the findings from that, and then I'll ask Councillor Matthew Brown to give us some reflections on that and where the model has gone since then, and potential lessons learned for other local authorities. So my name is Ben Barr, and I'm a professor in public health, lead the Improving Population Health team, and Councillor Matthew Brown is the leader of Preston City Council. Okay, so I will just try and share my slides and go into that outline of the research.
It's the green button at the bottom, I discovered.
Yeah, I think I'm getting there. Okay, can someone let me know whether you can see the slides?
Yes.
Great, thanks. So this is a research project that was funded by the NIHR, looking at the health, social and economic impacts of Preston's community wealth building programme. So what is community wealth building and the Preston model? And Matthew will be able to give you sort of more information about this. But essentially, it's an approach that can be taken to try and develop the local economy in a way that's more inclusive and more equitable. It's got a number of different components. So working with anchor institutions. So there's a sort of large not-for-profit organisations like the NHS, local authorities, universities, and using their economic power to try and influence the local economy. So that could be through changing procurement policies, so supporting the development of local businesses that are more likely to kind of produce more social value, supporting the development of local enterprises that are more accountable to the local population, such as cooperatives, investing local wealth, like pension funds in the local economy, improving recruitment and employment, both within those anchor institutions and their suppliers, and using land and property owned by anchor institutions for activities that promote inclusive economy and well-being. So the work in Preston started so initially around kind of 2013, and one of the things that one of the sort of initial bits of work was work that was done with the Centre for Local Economic Strategies, where they worked with a group of anchor institutions looking at their procurement policies and looking at how much money they used and invested in the local economy, and then worked with them to increase that investment in the local economy and investment in social value. And so by 2013, when they kind of reassessed that, they found that they invested about 200 million more in the local economy. Another part of the kind of initial work around this was promoting the living wage. So Preston City Council was the first council in the north of England, I believe, to become a living wage employer, and there's a promotion of the uptake of that across businesses in Preston. And initially there was some indications that was having a sort of beneficial effect on the local economy, but that hadn't been kind of looked at kind of systematically, which is what we aim to do in this research. So we looked at a number of economic outcomes, but also looked at mental health and well-being outcomes, and to look at the effect of community wealth-building in particular. We look at how things changed in Preston, particularly after 2015, compared to a group of similar local authority areas, and adjusted for a number of other things that might have affected these outcomes that's separate from the community wealth building initiative. So we looked at the spend retained locally in the local economy, growth in the not-for-profit sector in Preston, changes in the employment rate, and changes in wages. Those are the economic outcomes. So this just shows the proportion of spend by the local authority, by Preston City Council, retained locally compared to a similar group of district councils. And unfortunately, there's only data available after 2015 for that, and only data from local authorities. We weren't able to look at other anchor institutions, but in terms of the City Council, clearly they spend a lot more of their money in the local economy compared to other similar places. So between 25 and 50% of their procurement is with local businesses, whilst for other districts it's only about 15%. And that's been consistent from this period, from 2015 up to 2022. Looking at wages, so the green line on these plots shows the change in Preston before and after 2015. We saw a marked improvement in wages, so about 11% increase in wages compared to the control areas. That's about an additional £38 per week. Improvements in employment, about 6% increase in employment in Preston compared to other similar areas. And from 2017, we started to see a greater growth in social enterprises, not-for-profits, increasing by about 6%. So that was about an additional sort of 20 not-for-profit organisations compared to other similar places. So we clearly see this better improvement in the economy in Preston compared to other sort of similar places, but was that growth more equitable? So when we look at wages, we can see that improvement in the wages in Preston was particularly focused on the lower wage end. So for people, the 20% of the population on the lowest wages, they saw a much bigger improvement in their wages, 20% improvement in their wages following the community wealth building, compared to higher ends of the kind of wage distribution. So there was basically an improvement equity in wages during that time. Similarly, when we look at the improvements in employment, they were much greater in people with lower levels of education, so people with secondary or lower education. They were much greater with people with disabilities compared to people without disabilities, and amongst Black and ethnic minority groups. So the effect on the economy was an improvement in the economy, but also that it was more inclusive. And then when we look at the mental health measures, we saw an improvement in life satisfaction in Preston compared to other similar areas, 9% improvement in life satisfaction. And we use this composite mental health index, which shows poor mental health, basically. And we saw a reduction in poor mental health in Preston compared to other areas. And that translated into a reduction in antidepressant prescribing and diagnosis of depression. So about 600 fewer people being diagnosed with depression, that was equivalent to. So we can clearly see that activity of focusing on the economy and using the levers that are available to local agencies in the economy, having an impact on the economy that is more equitable, but that also then translates into benefits in terms of health and well-being. And these studies are published in a couple of journals there. So we can clearly see that there's that kind of approach can have an effect on health and well-being and inequalities within a relatively short time period, and it's particularly growth strategies that focus on those reducing those economic inequalities that have the potential to promote health and well-being. So I'll hand over now to Matthew to give his reflections on the research and how that has potentially been used, but also where things have gone from there, and the sort of potential for the future. Matthew, are you out there somewhere?
Yes, Mark. I'll just share my screen. Just bear with me a second. Let's see now.
It's Matthew. Sorry, Matthew Brown. We seem to have the wrong.
Oh, sorry, Mark. Sorry, Brian. Yeah.
I was
Apologies.
Matthew, you are there. Matthew Brown.
I am indeed here. Good morning, everyone. I'm Councillor Matthew Brown. I'm a politician. I'm leader of Preston City Council, but I also work for an international economic think tank called the Democracy Collaborative to spread community wealth building in this country and overseas, because it's very much become an internationalised movement about how we have a more fair and democratic economy. However, in terms of the research, for us in Preston, it was invaluable because we started this journey probably about 10 years ago in terms of community wealth building, and our instinct was this is the correct thing to do. However, obviously getting a research project to the scale that was studied, and obviously seeing the benefits, which was really, really positive for us in Preston. So it did basically tell us things that are pretty obvious, that if, like we did from 2013 onwards, if we pay a real living wage to our staff and encourage it across the local public sector, and Preston is very much a public sector led town. We've got 2 councils here, we've got a university, a hospital, housing associations, the police are headquartered nearby, and the rest of it. We will see an uplift in people's wages, and they will actually be less depressed if they're on a real living wage. If we see an expansion of affordable housing by ensuring that public sector land is used to build new social and affordable housing, then housing stress will be reduced a little, so people have more opportunities for affordable housing. And obviously, if we're buying local and basically procuring from not distant corporations, but from family-owned businesses, which we did a lot with construction, which themselves have a network of local suppliers that are based in the community, there's less wealth extraction, there's more jobs. So What we did see during that period, as Ben has shown, is that the increase in employment was, I think, 3.9% compared to other areas that were adopting community wealth building strategies. So that's very common sense. So when the council, for example, was regenerating our city and doing it in a way where we support local companies, there were 50 extra jobs on our markets that we redeveloped. There were about 150 jobs regenerating our bus station, and there's about 80 jobs where we demolished our old market. So this is creating jobs in the community and supporting locally based enterprises, which are often small businesses, which we know from studies from the Federation of Small Business and others do create more jobs and keep more wealth within the local economy. But I really want to pick up on what community wealth building is and what we've been doing since the study period ended, because the study period ended mainly from 2019 and onwards. And if you do research some of the cooperative economies in Italy or Spain, what you do see is that the more that we have cooperative businesses and democratic businesses, like employee-owned businesses in communities, you basically see that not only is the economy better and there tends to be less unemployment and higher wages, but you also see that public health outcomes improve. So there was a very interesting study done about 10 or 15 years ago looking at Italian cities which would have, say, 25% cooperative ownership in the city economy, 12% of very few cooperatives. And it did show that mental health, the levels of violence within the community, obviously, and other things like life expectancy were a lot better when cooperatives are more predominant in local economies. So within Preston, since the research period ended, we really are trying to create a more democratic economy, because working class communities like Preston, diverse working class communities, we've really suffered from austerity policies, but we've also suffered from our economic model and how it really, doesn't benefit many people within our local economy and community. And this is why we're looking at community wealth building and doing things very differently. So if you walk around Preston now, what you see is a city centre that's being regenerated primarily in public ownership. So those assets are retained for the community. And we can then, for example, promote living wage contractors within the regeneration that we do. You see us supporting the establishment of worker and employee-owned businesses. You see us supporting community land trusts and cooperative housing projects. You see us working with our local NHS, which itself has procured masks from the pandemic from a Preston-based business, which created 120 jobs, and also looking at worthy recruits. So the targeting some of the recruitment strategies in our most deprived communities, especially on minority communities. You see an expansion of community energy beginning in Preston. You see us establishing a cooperative banking alternative, because the current mainstream banking system, there's some areas of our community where often local businesses and even individuals are written off because you live in poorer communities. And then you also see an insourcing of services and the council actually getting into the market and looking to do things like provide council housing again, and also how we can provide broadband for residents, potentially free broadband, by setting up a cooperative vehicle. So this is all being done to try and build a fairer and more democratic economy, because this is good, we feel, for our communities and for our people, but we also feel that it's good for people's mental health, because if you're working in a very casualised economy, if you're working in a very unequal economy, it has a real effect on people's mental health. And the biggest social determinant of ill health is proven to be poverty. We have some areas of this country where life expectancy can be, 84, 85, 86. And then due to poverty, there's other areas of the country where life expectancy is barely 70. And that is very much down to the current economic model that we have and the inequalities it produces. So within Preston, we're probably embarked on one of the biggest challenges going, trying to change the economic system to one that's fairer and more democratic. But from my responsibilities as a politician, I feel we've got to do this, because I just see communities sometimes who have very few opportunities, who are really struggling with poverty, ill health and inequalities. And I think promoting community wealth building and building on the positive outcomes that Ben highlighted before is something we can do actually to tackle those health inequalities, which are also a major public health concern. But please do some research about community wealth building, because it's a movement which is now an international movement. It began in the American Rust Belt around Cleveland, Ohio, where they looked at cooperative alternatives to get people in poor areas back into employment. But it's also become a movement across the country here. So, for example, in Andy Burnham's Greater Manchester, you've got the Greater Manchester Ownership Hub, which encourages retiring business owners to sell their businesses to the workforce as a worker and employee-owned businesses, or start a cooperative business, or support a social enterprise. If you go to Merseyside, you see the Metro Mayor Steve Rotherham, who's been working to expand the amount of community-owned housing through community land trusts within the region. If you go to Islington, you see the insourcing of services at Islington Council, which has insourced 380 million pounds worth of services back into the local council, which has ensured 1,400 people are uplifted to the London living wage. And if you go to Wales, you see talk of a foundational economy. And if you go to Scotland, you see legislation, which is being adopted by the Scottish Government to adopt a community wealth building approach across the whole of Scotland. And within that, you have NHS Scotland and Public Health Scotland that are supporting that endeavour, because they obviously see that the current economic model, as it's practiced in many areas of this country, is leading to those public health outcomes, which we're all here to tackle today. And then additionally, you see an internationalised community wealth building movement. There's lots of interest in this. And I think we just got to look at the trends of what are making people unwell. And that is often economic trends. And those economic trends are down to insecure work, low paid work, housing stress and inequality. So thanks for the invite today. It's been really good seeing these findings again, Ben, and obviously the outcomes there. But I think we've all got a responsibility in the field, whether it's a political field, a public health field, or a community contribution we're making to try to actually build a better local economy, which has better public health outcomes for our communities. I think it's the key question of today that we actually do that. So thank you very much. I look forward to the rest of the event. Thank you.
Thanks, Matthew. And yes, we've had a few questions in the chat, but I think we're
going to move on.
Time for questions afterwards, aren't we?
Yeah. So now on to Matthew Bond, please.
Hello, hiya. I'll just share my screen. Okay. So just let me know when you can see my screen.
Yes,
we can see it.
Fantastic. So this is my little presentation about some community work we've been doing as a research and development centre for Blackpool. Let's have a look. So first of all, I'm Matthew Bond. I'm the External Liaison Officer in research and development at Blackpool Teaching Hospitals. So we're based at Blackpool Victoria Hospital, and we've got a bespoke research unit up there with a team of over 60 people, including nurses, support staff, AHPs, lab staff and pharmacists, and also a data team. So part of my role I've been in the job nearly 2 years, and part of my role was to get research out into our Blackpool community to help improve local health demographics and to promote research in our local residents. This April, we achieved CRDC status, which is Commercial Research Delivery Centre status, after application. We were previously one of the leading PRCs, patient recruitment centres, in the country before this, specialising in phase 2 and phase 3 commercial and non-commercial research studies. So our community focus, we've been trying to emphasise on local relevance and accessibility to research, targeting health inequalities in Blackpool and the Fylde Coast. It's big news, all the inequalities in Blackpool, and it has been for quite a while. I won't go into them. So part of this journey was to build strong partnerships with schools, other NHS trusts, and other local community groups and VCFSE groups, which we are doing at the minute. So this study was given, well, we came across this study, and it was to do with local children in the area. And it was hosted by the University of College London. So it's a we go to schools and we do like a quick height and weight study with the children, and then they have a survey where they talk about their perceptions on nutrition awareness, body image and healthy behaviours, and living circumstance. And so far it's been quite successful. We've done 9 schools. We cast our net wide up and down the Fylde Coast. I must have contacted every single high school and primary school, and we managed to get 9 schools. So altogether we got 700. We've so far 766 children have participated in the study, and we've got 2 further schools planned before the end of the school year. And some of the schools that we have gone and done work with have been in some of the most deprived areas in the northwest. So it's really been interesting to see the insights. So there's a heat map of the schools we've done so far. And as you can see, we've done a few in Blackpool, and we've done one up in Thornton Cleveland's area, and one in Bispham, and then one in Kirkham as well. So it's been a real mix of schools that we've done, both high school and primary school. So why the study matters. So first of all, it tackles childhood obesity and health inequality. And that's really been evident, like I said, in some of the more deprived areas. So it feels good to, feel like you're making a difference. And it builds early awareness of healthy lifestyles as well through the study, because some of the questions were quite direct to the kids, about how they feel, and on areas such as the traffic light system on food packaging, and other areas like that. And the data created will inform future public health strategies. So for one of the schools that we did, we used Manchester BRC's fantastic mobile research unit, which is like a clinic room on wheels. It's fantastic. The kids loved it. It was a great day out for them. And we had this at the school in the playground, and it gave us the safe space to do the heights and weights in privacy. And obviously it's full of our branding, which they loved as well. And we've also been in communication with Lancashire South Cumbria Foundation Trust about using their van for one of the upcoming schools that we've got coming up, which is quite a big school. So it's really been great to collaborate with other trusts on using their van as well. It'd be great to one day have a van of our own, but so through mobile researching, obviously it's more inclusive. We can actually go to people. We can be flexible and accessible, and we can go out to these underserved communities that might not always feel comfortable coming into an NHS setting to even consider doing research or trials. So looking ahead, we do plan to expand the use of the mobile research centres, or research buses, if you will, for more studies. So we've really got a keen eye out for studies we can take into community now. We've got 2 more schools planned, as I was saying, and community events planned. We have been talking recently about arranging a young person's event in our local community to get the opinions of of younger people in our community about health research and accessibility to healthcare. That's part of our PPIE strategy, patient participant involvement and engagement. And we've got continued focus on inclusivity and innovation through our PPIE group, which is, we've got about 11, 12 people at the minute, and we get together every 2 months for a few hours and talk about, accessibility to healthcare and accessibility to research. And we've got focus groups set up as well for future studies, which, their opinion to these studies is really valuable to us. And that's it. Sorry, I was quite quick with that. But any questions?
Oh, sorry, Matthew. We're going to do questions at the end, but thank you, because that helped us keep to time because we were running behind.
Thank you very much, everyone.
Okay, so now I think we're moving on to a recorded presentation from Rebecca.
I have Alan and Umesh speaking.
Oh, is it?
Now? Yeah.
Okay, sorry. So Alan, over to you.
Right, can you hear me? Okay. Right. Can you hear me okay?
Yep.
Yep.
Yeah, good. Okay. Right. LEADER, which now stands for Learning from the Premature and Often Unnecessary Deaths of People with a Learning Disability. This started a few years ago. The Department of Health and Social Care initially employed Bristol University to lead on the project. When their contract was up for renewal, it was instead awarded to King's College London in partnership with what was then UCLan, but as Umesh is right, it's now the University of Lancashire. Headed up that part of it, of course, by Umesh himself, who will be taking over from me in a couple of minutes. To put this into context, in the 2022 annual LEADER report, it said that the average life expectancy of somebody with a learning disability was 22 years less than the rest of us, and also that females died younger than males. Now, I'm not a researcher, but someone once told me that with this kind of research, you have to ask the 5 W's, which are who, what, where, when, and why. Unfortunately, Bristol, it would appear, didn't ask the why question, and although we learned an awful lot of information and data, we didn't really learn very much about why people were dying early. Umesh hopefully will tell us a bit more about the natural picture, but I'm just going to tell you a little bit about what the local reviewers are doing. The reviewers, as I say, are local people who have worked in the NHS, mostly nurses, who investigate the relevant deaths. People in the NHS who were caring for the deceased at the time of the deaths. These could be GP nurseries, hospitals, GP surgeries, rather, hospitals, care homes, nursing homes, etc. have to inform the NHS of the deaths, and they in turn inform the local reviewers. In the Northwest, the local team of reviewers covers Cheshire and Merseyside and the Greater Manchester ICSs. I'm not sure about Lancashire and South Cumbria. The reviewers then ask a considerable number of questions. They start by obtaining as much detail as they can about the person in question. Umesh, can you put the next slide on, please?
Is it moving?
No, at least it's not moving from it. Now it is.
Oh, yeah. Oh, that's come down a few.
So, okay, sorry.
Details of the person who died, it should be. There's one up from there, but don't worry. So they start by getting the details of the person who died, the name, age, gender, severity of the learning disability, which can be moderate, severe, or profound, and or autism. Autism was added in 2023, I think, if I'm wrong, Umesh will correct me, the age at diagnosis and the normal address. Next slide. Details of the death, where and when they died, did they die? If in hospital, did the hospital provide a structured judgment review? Was the cause of death as described in the medical certificate? And does the reviewer have any concerns, and if so, what? Next one, please. Other details. Here we are. NHS surgery, etc. Next of kin. Anyone else who knew them well, reviewers' details. And the next, please. Conversations, details of conversations they might have had with the family, carers, friends, other carers, the GP, anybody who might never have really known this person. And the next one, please. So they're trying, as you can imagine, to get as much details as they can, not just about the death, but the person themselves. This is basically this one, the assessment of care provided and the circumstances leading to the death. It's basically a summary of all the stuff so far, and can often lead to questions that then go on to lead to a focused review. And the last of my slides, please. The reviewer's judgment on priority for a focused review. This isn't always the case, but it's in these reviews where I actually get involved. I'm involved as an expert by experience, i.e. I'm a carer. There are also 1 or 2 people with a learning disability who are involved. But I'll just basically rush through this. And I'll give you an example. This is one I was involved with just a few weeks ago. It was during a focus review that I saw that a person who lived in a care home, but was in hospital at the time when they passed away, he died while in hospital, as I say, and the reason given was self-neglect, because they hadn't taken their medication. However, looking at the details, it appeared that the hospital wrongly assumed that the person had the mental capacity to take their own medication, which they didn't, by looking at what was stated on the usual carers. Unfortunately, I've seen a number of similar cases to this since then, which is really very sad. But one bit of good news, only last Monday, the NHS published guidance and practical tools for frontline clinicians in acute and community trusts to ensure that the Mental Capacity Act is applied properly for people with a learning disability when they're in hospital. If you look at the Mental Capacity Act, it actually says it assumes that people do have mental capacity unless they can prove otherwise. Now, how they find out if the person with a severe learning disability can prove that he or she doesn't have a mental capacity is beyond me. So they're now, as I say, they're provided this stuff to let people, clinicians in the hospitals and the trusts find out. So over to you, Umesh.
Thank you, Alan. I'm assuming everyone can hear me okay?
Yes.
Oh, good. Sorry, multitasking is not my my forte, but I'll try my best to present on Zoom. So my name's Umesh Chauhan. I'm a GP in East Lancashire, also Professor of Primary Care at the University of Lancashire, as it is now. And we work as a collaboration with King's College and Kingston University, along with the Staying Alive and Well group. And we have an advisory group as well as a wider consultation group that oversees the work, along with NHS England, who act as our kind of conduit for the report that's published. And perhaps this will be a challenge for us in terms of what happens in the future. And as Alan's pointed out, what we have is a process where a number of deaths are reported through a central portal on the NHS Leader portal, and those deaths are reported by various groups, including healthcare professionals, paid carers, and social care professionals. And these notifications are linked in with the death certification, the death certificate process that exists. And along with that, we include data such as ethnicity and whether somebody has a learning disability or autism. Now, obviously, the number of deaths over the years has increased in terms of being reported through the portal, and roughly we get something between 3,500 to 4,000. And as Alan said, for the last 2 years since 2022, we've had deaths of autistic people also recorded through the portal, and has been quite an important element of inclusion because this is a clear inequality in terms of how deaths occur, and these are individuals that it's important that we try and get more details in terms of what the causes of death are and how we can avoid them. And as Alan said, over the years we've now got data which has increasingly been useful to convince politicians as well as healthcare organisations about the importance of how we should manage and try and provide care for people with learning disability and increasingly with autistic people. And the data was quite clear for us to show during COVID, for example. So we had the peak deaths occur during that time, but it was again, the number of deaths that we saw for people with learning disability was far greater than the general population. And overall, when we look at data, what we can see is that there's a significant difference, at least 20-year difference between the general population and people with learning disability in terms of earlier causes of death. And the causes of death, such as cancer, circulatory problems, respiratory problems such as aspiration, are greater in this population, and we can start looking at the underlying reasons for that. For example, bowel cancer, we know that uptake of screening is at least 20 years difference, but people with learning disability also have an earlier causes or earlier presentation and incidence of bowel cancer, which we need to look into in terms of what that might be. And constipation, for example, is a cause of death that you wouldn't see in the general population, but we do see cases which are unrecognised at the time of death and a cause of death in people with learning disability. And overall, what we know is that 42% of deaths in people with learning disability could have been avoided compared to 22% of the general population. And these again are related to cardiovascular disease, respiratory disease, as well as cancers. And what we've now been able to do is generate data as well as evidence and some of the presentations around constipation and the role of specialist learning disability liaison nurses and the impact they have in improving the care of people with learning disability. We've now been able to publish and provide greater evidence for folk like NICE and NHS England in terms of how they should be looking to try and improve the care of people with learning disability. And the value of having data now nearly for 10 years is that there is a large database, and we are able to now explore what happens over time in terms of causes of death in these people. And with the additional level of information that we get around autistic people, this is also an important thing that we should be able to highlight. So that has been a delay in providing the leader report for 2023, largely because it's sitting with NHS England and the Department of Health. This is one of the reports that has to be approved by number 10. So we're waiting for parliamentary approval. We have a number of what we call deep dives that looked into causes of death, such as aspiration, pneumonia, and cancer, as well as cardiovascular disease, and the specific role causes of death that people with severe and profound learning disability experience, and these are all published on our websites. Obviously, this is work that's a collaboration across a number of universities, and this is a name but a few of those people. And I'm aware that time is short, so I'll say thank you now, and hopefully we'll have questions at the end.
Thank you. So I think now we're going to be having a short 10-minute break, and then we'll come back for discussions for these 3 presentations. So please come back at 11:10. If people are back, could you please turn on your cameras and we'll make a start for the Q&A session? Thanks, everyone. So we'll just start with the questions that were put in the chat. And for ease, we'll just go in presenter order. So starting with presentation 1 from Councillor Matthew Brown and Ben Barr. So Alison Doherty asked, did the public procurement regulations present any challenges to the Preston model?
Yeah, I don't know if Matthew, you still there? Oop. Not sure if Matthew's still.
He's still in the meeting. I'm just not sure. He might be on his computer.
Oh, right. I mean, I can try and. I mean, I think so. Yeah, there was a new bit of legislation that came in a little while ago, the Social Value Act. So that does give councils and other organisations more freedom as to how they procure services, so that they can basically kind of ask companies to basically try and meet social value outcomes as well as just financial and efficiency targets. So I think that did make quite a lot of difference in terms of how they were able to modify procurement. And there's also, I think, a question around kind of protectionism around, you know, if you're buying more stuff from the local economy, is that, you know, just you're not necessarily getting the best value for money in doing that. But where we looked at it, we compared contracts in Preston to other places, but actually there wasn't any evidence that you're getting less value for money from buying locally. So you can basically, you know, include sort of social value as one of the elements. But Matthew, I don't know whether you got any. There's a question about, you know, whether there are kind of constraints in terms of public procurement regulations that made it difficult to do what you wanted to do in terms of community wealth building.
I think there probably are, yes, but I think you can be pretty creative in getting around them, because there's things that councils can do as well as health authorities as well. For example, breaking contracts down into lots. So instead of having a contract worth 30 million, it might be 10 or 15 lots of 2 or 3 million. And that then means basically that the locally based companies or social enterprises or cooperatives or voluntary sector organisations, they've got more of a chance of bidding. So they are a bit of a hindrance, but there's ways around it that can be achieved pretty easily if you do have a bit of creativity.
I think one of the issues that was a bit of a challenge, I think, was particularly around kind of NHS procurement, which is quite sort of centralised. I think there's quite a lot of constraints for local NHS organisations to try and do things differently within the local economy. But I know that the trusts in Preston have been kind of working on that and trying to work around some of those things.
Okay, thanks. So moving on to, I guess, because Paula and Hillary's questions are linked, but Peter's question. So what what were the control groups? What are the other similar places? And how similar were they?
I mean, we used a lot of different control groups for different parts of the analysis. So for some of it, we matched neighbourhoods in Preston with other places sort of in the north that were similarly deprived and had similar kind of population density, and matched places on a whole range of factors. For some things, you know, for some of the analysis, so looking at procurement, however, we matched obviously on the kind of council structure, because so matching them to similar district councils of a similar size that are procuring similar services, basically. So a number of different approaches, and we did various sensitivity analysis looking at using different kind of comparisons, and that didn't make any difference to the conclusions that Preston was bucking the trend compared to similar places during that period.
Okay, thank you. And so then Paula asked, are there future opportunities with the devolution agenda to implement the model across Lancashire more widely? And Hilary asked relatedly, seems like cities and larger towns with more large not-for-profit organizations may have easier access to develop a community wealth building model. How can this be made more feasible in smaller towns away from central hubs?
Matthew, did you want to have a go at that?
I can try. I do think devolution does do some things that can support this agenda. I think having an elected mayor is a really good thing often for this agenda in terms of further economies, because, I mean, take a figure like Andy Burnham, he has a huge amount of control over assets, budgets, but also he has a convening power, so he could get together all the place-based institutions within Greater Manchester that'll probably spend tens of billions and get them behind this agenda very strongly. So I think devolution is helpful, and I think there are some positive powers around, for example, councils being able to set up bus companies again, because, you know, I was born in the 70s, and just in terms of deprived residents of the need to, say, get to hospitals or GP appointments, what we did have back then was councils running bus services that were pretty efficient, they were pretty cheap, and they were pretty positive in the services they gave. And obviously, I think the current transport operating models that we have at this moment in time is not very positive in terms of supporting communities, and especially supporting less well-off communities. In terms of community wealth building and how it could be implemented in areas which might have, say, a large council or lots of not-for-profit institutions, well, I think it could be implemented everywhere, to be honest. You know, I think it's sometimes more difficult if you don't have a lot already, but I think community wealth building can be applied in many places, because you're always going to have a local council, you're going to have some kind of health provision, you're going to have a police force, you can then use those economic levers to do similar. But I mean, it's, say, for example, in the more rural areas, so there's lots of conversations around community ownership of energy, community ownership of assets in villages and other things. But also, if you're talking about local farmers, the farmer community, I mean, lots of NHS trusts now are looking to purchase food from locally based farmers, and that's what we did in Preston, when school kids were fed by companies in Preston which were linked to local farmers. So this can be adopted in many places, to be honest. It doesn't have to be in large cities where you've got a quite vibrant not-for-profit sector. It can be adopted in many places. Thank you.
Thanks, Matthew. So now moving on to presentation 2. So Matthew Bond, Dorcas asked, as a recruitment centre within Blackpool diverse communities, can you please tell us how you managed to reach those communities with English as a second language and others who are really marginalised?
Heather, I think you might have had to leave the meeting, so I'm not sure if you want to move on to presentation 3.
Okay, sorry, I hadn't realised that. So I can't see. Has there been any questions for presentation 3, or does anyone have any questions for presentation 3?
I could just add something.
Yes.
Somebody put in the chat the access I think it was Pete Dixon. No, it wasn't. Access to the 2022 annual report rather. Just in case anybody doesn't want to read the whole report, there is an easy read version in there as well. So it's very quick and whatever, getting all the facts rather than having to go through all the detail, etc., etc. That's all I wanted to say.
Thanks, Alan. So, sorry. So, Alan and Umesh, so what are your next steps in this research?
I'm not sure about next steps in the context. Well, there are a number of uncertainties, I think, largely because the role of ICB is changing, as is NHS England. So that might create some uncertainties in terms of how the work is done over the next couple of years. So we're waiting to hear really in terms of how, you know, the fact that we have data being collected to such detailed amount in terms of an individual's death is really important in terms of being able to influence and change how care is provided to people who are most vulnerable. But it would be a shame to see things disintegrate along with the ICB and NHS England. So we'll wait and see what happens.
Thank you.
I think something which is really important, Umesh might disagree with me on this. We've not had a chance to talk about this. And that is the thing that came out last week about the Mental Capacity Act and addressing the difference, if you will, between ordinary people and people with learning disability, and how the act should be applied differently. And because I think, Umesh, that you may well find that a lot of the things, you know, like for example, bowel cancer, people dying younger with bowel cancer because the people with a learning disability aren't reporting that or aren't telling anybody they've got tummy aches, say, for example. And do you know what I mean? And so on and so forth. And so consequently, it gets worse. I think also I would like to see the annual health checks improved. I think a lot of people do get them now, but I know, like my own sons, it's a 5-minute quick thing with the nurse, you know, and that's it. That's all they do. So I'd like to see that much more, in much more depth, should we say.
Okay, thanks.
Did
you have a question?
I just want to make a comment. It doesn't matter who is there as the provider, either the ICB or the NHS provider. How cannot the act, when this review is done, that these vulnerable patients are dying of constipation? You know, I just feel this research should have something to have impact on the care of these patients. That's my view. I just feel in this stage, we couldn't hear that patients dying of constipation, you know, that and is it reflect on the GP or it reflects on the nurses or the hospital as well? And it's so sad, you know. So with your research, there must something that will come out from the finding that will make an impact and a change. And it's about pushing it. Umesh, you understand what maybe I'm getting emotional. No, that's what I'm trying to say. I think we need to do something about that. They're so vulnerable. They can't act on themselves. Their relatives or their carers act for them. And then they die. I think we need to do something about that. Thank you.
Thank you, Dorcas. Jamie?
Yeah, just a question about the autism study. I've attended a lot of autism talk clubs with Liverpool University. One of the things that's mentioned a lot from autistic people is about burnout and how that burnout necessarily. I just wanted to know whether your study will be looking into how burnouts and stress can result in early prognosis of like cancer and other illnesses, whether your study looks into tackling and managing burnout within autism.
I'm more than happy to try and pick up some of those points. That in terms of constipation, I think it is atrocious that people with learning disability are still dying from that. It's just unacceptable. Certainly, NHS England are looking to create a framework, a quality improvement framework for annual health checks to try and create standards for delivering health checks, which I think, you know, should make a difference in terms of how health checks are delivered. In terms of autism, Jamie, what we do, this is early days. We've only had 2 years worth of data so far, and we're not getting a significant number of deaths being signposted to us. But what we have noticed, and there's clear indication that self-harm is a significant cause of death. So I'm sure an underlying reason for that will be the stresses that people experience in a work environment, but also in society. So yes, we do need to explore this more. There is a greater risk of dying younger and people who are autistic, and we need to explore why and how we can avoid that.
Thank you. So just conscious of time, so now we're going to, thanks for everyone for the Q&A. If you have any other thoughts or questions that pop into your mind about any of the 3 presentations, please continue to put them in the chat. So now we're moving on to the second half of our sessions. So we have a recording from Rebecca Gearey on healthy urban places and GroundsWell.
Hi everyone, thank you so much for inviting me to talk to you today. I'm sorry I can't be there in person, I was already going to another conference, but I hope you enjoy this brief introduction to 2 place-based research consortia called Healthy Urban Places and GroundsWell, and hear a little bit about how they aim to improve population health and reduce inequalities. Ultimately, our vision in GroundsWell is for happier, healthier, greener and bluer towns and cities. We hope that GroundsWell will give us the ability to evidence the long-term health and wider economic impacts of harms that arise due to a lack of quality spaces, giving our communities information to raise these issues in advocacy forever. And these spaces, shaped by and for the benefit of everyone, should make a significant contribution to reducing levels of and inequalities in non-communicable diseases. So I want to quickly acknowledge our funders, UK Prevention Research Partnership, and our partners. And if you'd like to know more about GroundsWell or sign up to our newsletter, you can use the website or the QR code.
Oh, sorry, I've made a mistake. Let me just go back if that's okay with everyone.
I know we're educating academics on shortening presentations, but wow.
Sorry, it's my fault.
No, that's all right. Don't worry, these happen, don't worry.
I knew it would be me. Sorry, everyone. Let me just reshare my screen and let's go back from there.
So now,
sorry. Sorry. I don't know why it won't go back.
I'd like to start by talking about GroundsWell. GroundsWell is a large partnership, 9 universities and many community and policy maker partners, all striving to make outdoor spaces healthy for all. This 5-year programme is funded by UK Prevention Research Partnership and it's approaching its final year. GroundsWell is all about maximising the potential of urban green blue spaces like parks, gardens, woodlands, canals to help prevent and reduce health inequalities. Research consistently shows that access to green and blue spaces brings mental and physical health benefits and has already shown that green and blue spaces are equigenic. But not everyone has the same opportunity to access and use these spaces and the benefits they can give. Our aim is to maximise the contribution of urban green and blue space to prevent and reduce health inequalities. We aim to achieve this through community innovation and better understanding simple and complex systems in nature and society. We're taking a systems approach, and that means it's about understanding how policy, practice, perception and people are connected. Together, these elements shape how, where and when people can use green and blue spaces. But we don't just want to understand the systems, we want to transform them to hopefully achieve greater impact and benefits. Combining innovative theoretical frameworks with advanced data science, including simulations, health economics and policy analysis will help us to drive this transformation. But really, it's community engagement that is central. We believe that true lasting change can only come from listening to and working alongside people directly impacted by these inequalities. We have an entire work package dedicated to co-production and citizen science, alongside an ambassador programme and an innovation fund supporting local community projects focused on improving and maximising the health benefits of urban green and blue spaces. We have 3 pioneer cities, Belfast, Liverpool and Edinburgh, and a UK-wide programme of work through 7 interlinked work packages and a cross-cutting health inequalities theme. These are indicated by this figure on the left, which demonstrates the centrality of health inequalities to GroundsWell. We have fantastic support from public advisors across the project, and special thanks in Liverpool go to Neil and Naheed for their support with GroundsWell. Ultimately, our vision in GroundsWell is for happier, healthier, greener and bluer towns and cities. We hope that GroundsWell will give us the ability to evidence the long-term health and wider economic impacts of harms that arise due to a lack of quality spaces, giving our communities information to raise these issues in advocacy forever. And these spaces, shaped by and for the benefit of everyone, should make a significant contribution to reducing levels of and inequalities in non-communicable diseases. So I want to quickly acknowledge our funders, UK Prevention Research Partnership and our partners. And if you'd like to know more about GroundsWell or sign up to our newsletter, you can use the website or the QR code. So now I'd like to talk to you about another project called Healthy Urban Places. Healthy Urban Places is a 4-year programme working with communities and local partners to better understand how local urban places impact health and what improvements could achieve the best outcomes. Our approach focuses on generating this understanding with people in a way that can influence policy and practice to make our urban places healthier for everyone. Healthy Urban Places has just finished its 1st year. So we already know that the places we live in can affect our health. Most of us in the UK live in cities, so making sure cities are healthy places to live is important. Things like clean air, good quality housing, access to green spaces, shops, arts opportunities, schools and health services all make a difference to our physical and mental health. And every neighbourhood has a mix of things that can help or harm your health. Unfortunately, some areas have more unhealthy environments, meaning people living in these areas can experience poorer health. By improving our urban places, we have an opportunity to improve the health of the communities most in need. But what we should improve needs more consideration. We understand some of the ways these changes may influence our health, but what we want to understand is which combinations of changes may improve our health, particularly for those who need it the most. In Healthy Urban Places, our research taking place in 2 areas, Bradford District, West Yorkshire, and the Liverpool City region. Both areas have rich histories, varied geographies and shared challenges. Liverpool is the 3rd most deprived local authority area in England and Bradford's the 13th. Many health and wellbeing measures in Liverpool and Bradford are also worse than the national and regional averages and both have high rates of child poverty. We've also chosen these places because they both have large research studies and connected data for over 3 million people, which will help us understand how local places influence our health. We are bringing together researchers, residents and communities with local government, public services, community organisations and businesses to co-produce research in 2 community collaboratives across 8 neighbourhoods. By involving those who are impacted by and responsible for decisions about local places, we aim to co-produce relevant, impactful research. Through the community collaboratives and connected data, we will jointly answer our questions of what makes a healthy place. And we'll also work with local partners to evaluate the impact of existing and future changes to places to understand how they impact health and wider society. Healthy Urban Places is hosted by Barr in Bradford, and it's a consortium of 10 organisations, including the University of Liverpool. It's part of Population Health Improvement UK, a national research network which works to transform health and reduce inequalities through change at the population level. You can find out more about Population Health UK, Improvement UK, here at this website. So as my talk draws to a close, I'd like to ask you to turn to the person next to you and ask, what does a healthy place mean to you? If you'd like to share your answers to the Slido on this QR code, it would be amazing to see what comes up, and we can share those results after the ARCFEST too. And finally, I'd like to say thank you all for listening. I hope you enjoyed hearing about healthy urban places and GroundsWell. And if you'd like to know more or explore getting involved, please do get in touch with myself, Ollie Butters or Sarah Rogers. Thanks so much.
Okay. So if anyone has any questions about GroundsWell or healthy urban places, please put it in the chat so we can get back to the study team. So next we have Kristof.
Hi. Hi, Heather.
Hi.
Can you see me and hear me?
Yes, I think the wrong Kristof is spotlighted on this. So Kristof Santov, can you speak? Santa, can you speak again, please? Oh, there you are. Okay, yeah, you're all good now.
Okay, thank you. I shall be sharing my slides. 1 second. Okay, can you see my slide currently? Slide 1.
Not yet.
Not yet. Okay, 1 second. Hold on. Now, can you see my slides now?
Yes.
Okay, fantastic. Thank you. Okay, can you still see the slide I am sharing?
Yep.
Just double checking. Okay, thank you. So I am Kristof Santa. Good afternoon, everyone. Thank you for having me. I am a research assistant at the University of Liverpool. And I am glad to be here to share a brief overview of the work we have done on the Fight Coast as part of the Community Solutions for Health Equity, a project of the Fight Coast Research Collaborative. This was funded by the Mobilizing Community Assets to Tackle Health Inequalities program, and which was led by the Arts and Humanities Research Council. Barbara Mezes was the principal investigator on the project, and she apologizes for not being able to be here to present. First of all, we would like to thank our co-researchers, co-investigators, and partners who were involved in this project. This project was led by the Fight Coast Research Collaborative, as mentioned, who brought together an interdisciplinary team to focus on health inequalities on the Fight Coast. The funding allowed us to expand the team, adding partners from the creative and cultural sectors. The collaboration included expertise in arts, heritage, health economics, mental health, and public health. While most activities took place in the Northwest, we also partnered with East Sussex, hosting a knowledge exchange event to mobilize community assets in coastal areas which shared characteristics like Hastings and Blackpool. So the context of the project in general. The Chief Medical Officer's 2021 report highlighted that coastal towns are or were facing significant health challenges. Issues such as poverty, poor housing, limited opportunities, and the low-wage economy contribute to major diseases, including mental health, leading to lower life expectancy compared to their inland neighbors. However, coastal towns also have many community assets, including creative ones such as arts and cultural organizations, and other assets such as libraries, community hubs, charities, and citizens' advice services that have the potential to improve the health and well-being of the residents. The challenge lies in effectively integrating these assets into the health and social care systems. New legislation encourages better integration between NHS, local councils, and other strategic partners like the voluntary, community, and social enterprise sector organizations. But the complexity and diversity of the ecosystem makes this a challenging task. So our aims and on the project were to deepen the understanding of the community assets on the Five Coast and explore existing collaboration patterns. We also wanted to mobilize the knowledge of people living and working in the area and co-produce community solutions for some of the research and service improvement needs. We wanted to enhance research capacity and skills in the community, and we wanted to connect with other coastal towns with shared characteristics and challenges, for example, Hastings. To achieve this, first we started with a provision mapping exercise that also provided basis for data collection with the social network analysis. We had 2 shorter co-production groups and 1 longer that was running over 3 months, focusing on better integration of community-based support and assets in community hubs, and action plan for place-based partnership to work across sectors, and a future research agenda for coastal communities. Alongside these, we had monthly research capacity building workshops. Some of the sessions were pre-planned, while others were intended to support the work of the co-researchers in different co-production groups I just mentioned. All are available freely online. We had a learning and knowledge exchange events co-hosted with East Sussex County Council, which was attended by over 60 people from the 2 areas. And we also submitted a joint grant application across the 3 coastal towns, which was successful. So moving on, Heather, can I just check you can see me changing slides due to the technical help issues? Okay, thank you. Okay. So this was the overall project. We have recently published a peer-reviewed publication on the results of the first aim of the project. And I will be focusing on this publication for the remainder of the presentation. The study was titled as Collaborative Networks in Community-Based Health and Social Care Services, Insights from Blackpool and the Five Coasts. So this was based in the United Kingdom. The article is available via the QR code, but I can put the link in the chat once I finish as well. Okay, moving on. This study focused on community-based health and social care services, which included service provision and activities in community settings in Blackpool and the Five Coasts. We used a cross-sectional design combining a mapping of organizations with social network analysis. Social network analysis, to put it in simple terms, is a way of studying relationships between people, groups, or things by looking at how they are connected, like a web. And it helps to understand who is most influential and how information flows or can flow, and how groups are or can be structured. So we collected data for the social network analysis, and this was carried out from March to June 2023 with the help of our partners. from the VCFSE sector, and an adapted version of the template for intervention description and replication, or short TIDIR form, which is a mouthful for sure, was used. And this survey gathered information on each provider's health and social care activities and a list of their collaboration partners from a roster of organizations, which was identified from the mapping exercise. The services were categorized into 11 service domains, and based on their primary functions, such as mental health, housing and shelter, or family support. We categorized service domains based on their primary function because there was overlap across these sectors or services. So we had to restrict to a more categorical organization. And the main analytical approach was social network analysis, as I mentioned, and we used various softwares to do this analysis, such as R, to create visual representations of the network, calculated key metrics, including network density, which showed, for example, how connected the network is overall, and centrality measures. This included degree centrality, which indicated how many direct collaborations an organization had, and betweenness centrality, which identified organizations that act as bridges between others in that specific network. We also used advanced statistics, sure, that was MRQAP, it was a regression model, and we used it to analyze collaboration patterns and tested whether organizations were more likely to collaborate within the same service domain or across different domains. So as I mentioned, before we conducted the social network analysis, we conducted a mapping exercise. And we mapped the fullest practical range of community-based support providers, aiming to support public health and well-being simply. These were local authorities, VCFSEs, NHS organizations, clinical communication group websites, and social media organizations as well, for example, who were only present on Facebook. So we tried to map the entire sector in this sense. 453 organizations were identified and contacted, and we have identified 11 service domains. And 44 organizations responded to the online survey via the TIDIR form. This was unfortunately standard, even though this was a low response rate based on previous evidence. And these provided information on collaborations across 321 organizations. So this figure on the left shows the organizations and their connections between them based on the data we have received and analyzed. The lines or the lack of lines represent categorical variables, so yeses or nos, whether a collaboration exists or not, or a connection exists or not. And the colors on this graph represent the particular service domain. So again, there were 11, and there is a list. I hope you can see it, top right corner on that graph. And the circles are organizations themselves, and the more central they are on the graph, the more collaborations they had. The findings also indicated that on average, organizations collaborated with 7 other organizations, and the majority collaborated with 1 to 5 organizations, whilst one of them was found to have 74 ties, which is quite a high number. The observed network had a relatively low density, that was 2.2%, which highlighted the potential for more collaborations. Housing, so back to this figure, housing, shelter, and nutritional support seems to be the most central service domain in both data sets, both in terms of degree, which was the pure number of relationships, and betweenness, the importance of the organization as a bridge between the other organizations. However, economic support provision, for example, appears similarly important degree-wise in this respondent subset, with community cohesion and belonging organizations also being more central in this subset, especially degree-wise. We also investigated homophily. Homophily stands for organizations or the tendency for organizations to collaborate with organizations operating in the same service domain. So how likely they are to collaborate with each other in the specific domain, for example, mental health. In the current context, homophily can limit an integrated system from addressing broader social determinants of health and lead to fragmented service delivery, for example. In contrast, between service domain collaborations can strengthen support networks through dividing responsibilities on the basis of strengths, sharing best practices and knowledge, and amplifying the sector's voice as well. So by the study, we have detected a significant homophily, whereby organizations tended to partner with organizations from the same domains rather than other domains. This was true for housing, shelter and nutritional support, child and family support. So I'm reading off the table: mental health support, community development, and campaigning and economic support provision. So those, excuse me, those organizations that didn't show significant homophily on the rights, they weren't more likely to collaborate across, but they were just as likely to collaborate across as within. So there was no difference in that sense. And this overall really highlighted the interaction between multiple factors underpinning complex needs in areas of high deprivation that require, for example, joint response from service providers in these service domains highlighted. In conclusion, or overall, the network structure showed a small number of highly connected organizations providing diverse support and a larger number of more isolated ones, as per the first graph, suggesting that the vitality of the entire network in this context may depend on the stability and engagement of a few key players. For example, that was one I mentioned with 74 connections. This imbalance could lead to increased fragmentation, particularly if central organizations reduce their involvement. The network also appears fragmented, with limited overall collaborations, but this is not unexpected, as organizations are unlikely to be able to collaborate with hundreds of others. So most organizations were found to collaborate within their own service domains. Again, for example, housing, mental health, child and family support, rather than across different areas. But this homophily at the same time highlights a gap between current collaboration practices and the ideal of more integrated, holistic, and care promoted by health and care policies. And this limited spread of cross-domain partnership may restrict the ability to address the complex, interconnected challenges faced by communities. The importance of this is twofold. First, there seems to be less collaboration across domains, which contrasts with the comprehensive care proposed by legislation relevantly, as well as the ICS indicating a potential discrepancy between the ideal and the observed integration as per our study. Current public health challenges seem to need or require a more or transdisciplinarity to tackle the complex interplay between social, psychological, economic, and environmental factors driving both mental and physical health outcomes, highlighting the overall need for improved cross-domain collaborations. And secondly, we found more collaborations between domains which align with the priority areas of place-based partnerships, housing, mental health, first 1001 days, and education, employment, and skills as well, which also show the importance of high-level buy-in potentially and investment of resources and support for priority areas to translate into more collaboration between these domains. Even though a major barrier to collaboration is the lack of coordinating infrastructures, seems to be the one within the voluntary community, faith, and social enterprise sector organizations in this region, so Blackpool and Fife Coast, this gap limits the opportunities for partnership building, resource sharing, and collective action. And the findings also pointed to challenges around shared data systems, which are vital for supporting effective collaboration and integrated care as well. And without these robust systems for information sharing, organizations may struggle to coordinate efforts, for example, and deliver comprehensive services, as we found as well that some organizations were located on the periphery with not many connections. Enhancing the strength or the effectiveness of place-based partnership can be a way forward to overcome these barriers that limit the integration of care services. For example, legislative reforms, including the Health and Social Care Act 2022 and the White Paper on Integration and Innovation, can provide frameworks to aid these efforts. However, their success depends not only on the implementation of organizational processes, sufficient data sharing practices, and community capacity building initiatives, but also on ensuring that the voluntary community, faith, and social enterprise sector has the necessary infrastructure to participate fully in these systems at the same time. This would allow for improved collaboration across service domains, better alignment with the community priorities, and a more effective response to persistent inequalities, I would say. Okay, and that is the end of my presentation. I would like to talk a little bit more about the
sorry, Kristof, we're out of time.
Yeah. Oh, we are out of time.
Yes.
Okay. Okay. Should I stop here?
Yes, please.
Okay, no problem. I will be sharing the slide later on if needed.
Excellent, thank you. So now we're moving on to the final presentation, which is Amelia, Simpson, Reuben, Larbi, and the co-researchers based at the Blackpool HDRC. And this is pre-recorded.
Hello everyone, we are the wonderful co-researchers of Blackpool's Health Determinants Research Collaboration.
We work on projects on Blackpool HDRC.
In this video we are going to share our experiences as co-researchers.
We hope you enjoy.
We are now going to share some reflections on how being part of co-research has been transformative and has led to wider opportunities.
Hello, my name's Sandra. I'm a co-researcher working for Blackpool Researching Together. I was recently involved in a project called Cllr, Cosy Homes in Lancashire. Cllr started in 2014 and it was a warmer home scheme across Lancashire. And the aim was to reduce fuel poverty, improve EPC ratings and reduce carbon emissions. We focused on Blackpool because that's where we're based. I worked on Cllr with an office from the Cllr project, an academic researcher and myself. And we all had an equal say and we were all involved in the planning and the development of the project. My role was, one of my roles was to interview the participants. So there were letters sent out to participants. Some were eligible but hadn't applied, and some had already applied for the scheme but maybe not been successful or not completed it. So we wanted to know why. Statistics show that Blackpool has 19.7% of households in fuel poverty, and yet there's been a very poor uptake on the scheme. So part of our research was to look at this and look at the reasons why. So by interviewing residents and households that were eligible or had started the scheme, we could find out their reasons from themselves, which was really important to get it from themselves. So the evidence that then will be used for further feedback to the schemes and to look at why people maybe aren't applying. And we got a lot of good information and suggestions from the participants. So that was all be put into a report and fed back, and hopefully improve things and take up for the future on other schemes.
Hi, my name's Sharon, and I was lucky enough to be involved as a co-researcher on a project dear to my heart called Let's Talk Menopause and Wellbeing. The project concentrated on women's experiences of menopause and the potential impacts on their mental health. As a society, we are really good at bottling things up, and this project allowed women to be able to express their thoughts and feelings around menopause. My desire to be part of the steering group and be fully involved in the project stemmed from my own experience, my lived experience going through menopause. The project's intentions were to gather insights from 3 different sources. So we looked at the women's perspective and how menopause has affected them potentially with their mental health. And then we looked at professionals, and in particular medical professionals, and we looked at family and family friends, whom again may have been impacted by knowing somebody going through the menopause. The aim of the project was to gain understanding of the aspects of menopause, particularly on mental health, and whether treatments or care treatments had gained the person experiencing menopause any relief. They were looking also at whether professionals had enough knowledge and training around menopause to provide that care for women in Blackpool. And we also hope to gain an understanding of how loved ones can be affected through knowing somebody going through the menopause. The project deliberately sought to co-produce and co-design with people with lived experience of menopause, including myself. And we did surveys and questionnaires, they were compiled, and then we did focus groups in particular areas. So we chose like the council office, we chose community centres, churches, we went to a group that supported women post-cancer treatment, and we went to a workplace just to gain an overall view from different women's perspectives. There was a WhatsApp group that was formed from some of the women that had been to the focus group, and that's still ongoing, which is a really good ripple effect of the project. And just as I've really enjoyed being part of the menopause project, and it's really given me confidence when I'm going forward with other projects. Thank you.
Hi, I'm Emily, a youth co-researcher at Blackpool Researching Together.
And I am Matthew, one of the co-researchers and co-research champion for Blackpool Researching Together. And we're here today to talk about Street Life, a wonderful Blackpool organisation that helps 16 to 25-year-old people who are going through multiple complex needs, mental health concerns, and are homeless in the community. So we got invited with the Bridge Research Network, as well as the NHS, who were delivering some training around creating research champions from those community members who are accessing the service. So we went along for the last 3 sessions, I believe, and we were there basically to promote what Blackpool Researching Together does, some opportunities they could get involved in, things like that. Had wonderful conversations discussing what types of research they're actually interested in from a community level, which specifically were around youth mental health services and support. Since then, they've actually worked collaboratively with both of us to form their own research question and put in an application for seed funding.
Hello, my name's Siobhan, and I was a co-researcher for Blackpool Researching Together. Before joining BRT, I was a stay-at-home mum. I had no formal qualifications, and I often felt like those opportunities were out of reach. But that changed when I stepped into the role of a community researcher. So for me, BRT was more than just a project. It was a turning point. Being part of the team, it gave me confidence and potential that I actually didn't know that I had. I was listened to, I felt valued and also encouraged, and that belief in me, it absolutely sparked something, and I began to see my own potential. And with that newfound confidence, I took a leap and returned to education. And I'm now actually in my 2nd year of my degree, something I never imagined to be possible before this experience. The impact of BRT didn't stop there. Inspired by the power of community and the importance of giving vulnerable people a voice, I went on to start my own family group in my local area. It's the second most deprived ward within the country, and every week we can welcome up to 40 people, and we just offer that safe space, really, where, you know, we offer a meal and just where they can connect and just be free and just safe. So I am proud to say, following on from the co-researcher, I was offered the role of the engagement officer for my area, and that role actually allows me to make a real change where it matters most. And I truly believe none of this would have been possible without Blackpool researching together. This journey has shown me the power of community-led research and what can happen, you know, when people are actually just given a chance, ultimately, given a chance, given a voice to just learn and be themselves and offer the value of lived experience. It's powerful. So yeah, really positive and grateful. Thank you.
Hello, I'm Matthew, one of the co-researchers for Blackpool Researching Together, also known as Blackpool HDRC. So I started my co-research journey as just a standard co-researcher until about 6 or 7 months in. Became a co-research champion, which had a lot more responsibilities, a lot more fun, a lot more trials and tribulations as well that are wonderful to work through. As for my individual, I guess, changes throughout that time, at the start, I was quite a critical person of what we're doing, very antagonistic in some ways, but for good reasons, at least I thought at the time. And I think that one of the most important reflections I've had since then is actually that the process that we work with is not only complicated and messy and a bit chaotic, but it is just how the processes work. It's not so much we had no clue what we were doing when we started, but more so that this is just how things play out. As well, one of the more interesting reflections that I have on my personal journey is also on the academic side. So I'm not only employed as a lived experience co-researcher, but I also have an academic background. And so far, it's been really interesting to dive more into that world specifically, because there's a lot of different attachments with the university, Lancaster University, obviously our partner in this collaboration effort. And as well, I always think that some of the most interesting and beautiful points of Blackpool's progression with co-research has been shown through some of our co-researchers who have actually left now to do other and greater things in some ways. So Chauhan, obviously, one of our co-researchers, now works in Claremont, servicing her community. Really inspiring story.
If you would like to hear more from us, please get in touch at hdrc@blackpool.gov.uk.
So I think now, according to the schedule, we have another 10-minute break, and then we'll have the final Q&A for this ARCFEST. So hello, everyone, and welcome back for the final sections. We are just going to start with our Q&A from the last bit of presentations. If anyone has... Oops, sorry, I pressed the wrong button. If anyone has any questions for the presenters, I think there's some points of reflection, particularly around the importance of involving community researchers, but I couldn't see any questions if anyone had, or anyone wants to have any other comments that they'd like to raise to the group, or if any of the presenters have anything else they would like to add. because we have about 20 minutes to the next section.
Okay, can I briefly, if you comment?
Of course, Reuben, please go ahead.
Yes, so thanks to everybody for listening to us. So throughout our operation of a co-research approach in Blackpool, as we may have heard from our co-researchers, we see the deep value of involving communities in research, which I think many of us will attest to that fact, both to enhancing the type of questions that we will ask, the design of the question itself, and also for the skills development for the co-researchers themselves. So over the period of about 2 years, this has been some of the key things which we think have great potential for enhancing research quality, particularly in research-constrained communities, and also the usefulness of research to inform local policy and practices. So thanks again for being part of it.
Thanks, Reuben. So, Kristof, one of the things that you found in your paper was about a lack of collaboration between organizations. And there was a comment in the chat about funding models contributing to that. Do you have any reflections on that?
Funding models contributing to that? It's a good question. I'm not sure I would have any kind of information on that, because the collaborations that we have measured, they were across organizations. So again, the way we collected data was that we sent out a survey and we simply asked which organization you are collaborating with. So we were aware of limitations of time and funding. So we had to cover all these certain things here. So whether the funding models contribute to that, I am not entirely sure. We didn't have the opportunity to cover that, unfortunately. You could email Barbara, the principal investigator who was on the project. She might have a different answer on this. I put her email in the chats, but that is the only answer I can provide. Hopefully that helps someone.
Thank you. And then I guess, Katerina, I know you put in something about your health equity mainstreaming evaluations, or anything that you want to say to the wider group about that?
Thanks, Heather. Just to say, please do the survey. It would be amazing. As you may know, across the Arc Northwest Coast, we have this whole health equity mainstreaming strategy with lots of different actions trying to see how we can best support anybody involved in health and care research to do that, taking into consideration health inequalities. You don't have to know what this strategy is about to fill out the survey. We just want to get some understanding of what has been helpful in the last few years for you or not, so we can also target our limited resources in the future much better and support you more in doing that work. Thank you.
Thanks, Katerina. So I guess the final thing before we potentially move on to the panel is, I don't know if any of the public advisors from the ARC have any reflections comparing their experiences with that from the HDRC and the community research model, if there's anything that anyone would like to add of comparing and contrasting.
I put that in my comments in the chat about, those projects, how fantastic they are, because they've taken them into the community, straight into the community. And it's about empowering those people that took part, especially the young lady, the young woman that is now doing a degree, which is quite nice. When you're doing a research, really, we can, as researchers, sometimes you do it from the office, but it's nice to see the research champions going out there, talking to people, and trying to make a difference, which I quite like. So I like it a lot. So I'm just trying to think that that's the best way to do things, really, if we can afford to do it. So yeah, go out there, do the research with them, but the feedback should go back to the community as well. The impacts from those small projects it should be highlighted. For example, does it make with menopause, has it made any difference within the practices of the GP practices? Has it made any difference the way women are treated in the offices? So all those things would be nice in future to see the impact those little projects have done. Thank you.
Thank you, Dorcas. Does anyone else have any comments? Any of the other public advisors or anyone else before? Keith, I see you waving your hand.
Wondering about what difference has social prescribing done for Blackpool Filed and Wire, if anything?
Exactly.
I guess I've sat here thinking 10 years on from Clark and the research that was done in Claremont, which was probably one of the worst wards in the country. So we're now with focusing to, I think Revo in central Blackpool isn't probably one of the worst in the country now. I wasn't sure what they were referring to when they said second in the country. But how are we going to change this after 10 years? Will we be saying this in another 10 years? That's what gets me.
Okay, I don't know if any of the presenters have anything they'd like to reflect on in terms of using research to reduce health inequalities. No. Okay, so shall we move on then to the panel discussion, and then people can potentially have an extra time to go eat some lunch. So we have on our panel, we have some of the presenters from the morning and afternoon section, and we also have Leon Cruikshank, who is a professor of, sorry, Leon, he does lots of things with communities and works in Imagination Lancaster. I can't remember your title, I'm terribly sorry. I should have looked that up before we started. So we have 3 questions that the panel is going to be discussing. And I guess we will start with, and we have Alan, the first question on, based on what you've heard today, what is the most impactful step our diverse organizations can take together to reduce health inequalities in specific communities in the Northwest Coast? And hopefully, Keith, that will answer some of, or address some of the questions you raised about being in the same place in 10 years' time. So I'll give over to the panel to address this first question. Should we start with you, Matthew?
What can be done to reduce health inequalities? I do think that we need to do a lot of the community wealth building that was mentioned in Ben's presentation alongside mine. But I also think the NHS potentially has a huge, and public health too, has a huge role as an anchor institution. So I just think we need to obviously support the NHS to do the brilliant work it does. But I do think it can do other things, like looking at whether it can itself recruit people in the areas which are the most deprived, recruit people from minority communities, disabled employees, women, often who are left behind in the workforce, make surplus land available for new social housing, support the local economy through worthy procure. I think that's a big opportunity to reduce health inequalities going forward. I mean, the biggest determination of ill health, according to public health professionals, from what I've read, is inequality. So I think reducing those inequalities is the primary goal, really, to actually move forward. And I think to do that, we need a very different kind of local economy. And to do that, I think we need to start now to do things in a very different way, because we do have lots of stress out there. We've got casualised jobs. We have people in poor housing conditions. We have people in homes that are lacking in energy efficiency. We have people who are suffering food poverty. There's a lot we can do now, just with a bit of creativity and collaboration. Thank you.
Thanks. Leon, do you have anything
So as we've established, I'm not a health researcher, although I have worked with health researchers, and there is a tendency for everyone to be gloomy. And when there's a call, what has changed in 10 years, and everyone sort of looks at their shoes, it really feels like there needs to be something radical that isn't, the next 10 years shouldn't be the same as the last 10 years with all the good intentions and money and energy and inspiration there have been in the last 10 years. So I don't have an answer, but it feels like there needs to be a big change, not a kind of, let's try the same thing a bit harder. But that's my view from the outside.
Thanks. So less tinkering at the edges.
Mm-hmm.
Excellent. So Alan, over to you.
Well, with regards to people with learning disability, of course, that's exactly what the LEADER project is all about. Reducing health inequalities for people with learning disability. But I was listening with quite a lot of interest to a lot of the other projects with regards to how well off people are, where they live, and so on and so forth. There's a fella, I live in St Helens, and there was a fella from St Helens Place told me in a meeting a few months ago that if you live on the west side of St Helens, a place called Eccleston, which is adjacent, if you like, to where Lord Derby lives, all lovely, green fields and woodlands and so on and so forth. Your life expectancy is 11 years longer than if you live on the east side of town, a place called Barr, where you're immediately downstream, as it were, or downwind of all the glassworks, Pilkington's glassworks. So there's a major thing there with regards to where people live in the town. And that's, how would I put it, unintended consequence of the Industrial Revolution, back in the 19th century. So I don't know how we deal with that sort of thing, but that would be very interesting bit of research going forward, I think.
Thanks, Alan. Yeah, so I guess it is thinking as well about these long-term structural changes and how we overcome them.
Yeah.
Excellent. So Kristof,
what we can't do, of course, in St Helens is demolish the whole of Pilkington, because then half the town would be, you take so much money out of the town by doing that. But I don't know. But there's got to be a way forward.
Thanks, Alan. Kristof?
Thanks. Well, the others mentioned a lot of insightful points. Based on our research, what I could or would want to mention is that we highlighted fragmentation of collaborations across the service providers we managed to acquire data from, and this showed the limited effectiveness of integrated place-based approaches. And even this approach aims to reduce inequalities in these regions by trying to improve these collaborations within and across the services. So what I could add as well, that this kind of cross-domain collaboration, better data sharing infrastructure, capacity building for VCFS organizations would be quite impactful towards the step of reducing inequalities.
Thank you. I see, Dorcas, you have your hand up.
Yeah, just a comment quickly. Anyway, thank you so much. We're talking about health inequality. We've been talking about this since Mammoth report. If we go back a bit, we've been talking about it, and yet we're talking about it in 2025. And he said, what single most important step we can take? I think what we can do now is to enhance the collaborative work that we're starting as researchers, to go out to the health providers, the social services, to make sure they work together. And then, because we've been talking about it, and we still have it, so I think we need to work more better. And ICB as well, and also the trust. We need to do something, they need to work together and make sure, the health inequalities continue to reduce. It has reduced, but we still got it. For me today, it's about collaboration. We need to work together more. The researchers, when they've done the research, let's see the impact. And how can we get into the practice? Let's use our members to get it into the practice, right? And let's talk to the community. But I like the one they say, you know, when you have money, you have good health, isn't it? So if you live in in Liverpool, your lifespan is lower than somebody living in the affluent Walton, which is in Liverpool, like we just mentioned now. And we can't continue to compare that. We need to stop that gap. You know, we need to stop the gap and make sure everybody is treated, you know, in a very quality way. Thank you.
Thanks, Dorcas. Andrew?
Hi, I don't know what's going on with Zoom. It's only my mum calls me Andrew when I'm naughty, so I'm Andy Pennington. I work for Ben's team in improving population health. Just a reflection on something that we might be missing. So, you know, we know that mental health for children and young people has deteriorated, and it was exacerbated by the pandemic. But actually, the mental health of people, even in the young people in the highest socioeconomic group, has deteriorated over time. We absolutely know that poverty and inequality are a big problem. But I do wonder whether we're missing community, whether we're missing the connections within community. We focus on poverty and adverse childhood experiences, but I was reading something relatively recently that was talking about the atomization of society. So if you think what our childhoods were like compared to what a childhood is like today, yes, it is about the internet, but you know, we're working remotely, we're all sat working remotely now, we're shopping remotely. We've had an increase because of the various consumer forces in society of families living further and further away from each other. We don't kind of have the older, well-meaning role models that are surrounding children that I certainly had when I was younger. We don't necessarily know the local shopkeepers and the people who are in our road, etc., etc. So I'm sorry, that's rather rambly, but I think we also need to, yes, we need to think about poverty and inequality, but I think we do need to go back and look at the breakdown of our communities as well, driven by the internet, by remote shopping, by commercial forces, etc., etc., or we're missing a very important trick. Again, sorry, that was rather rambly.
No, and thank you. And then there's just some comments in the chat. So Paula, you've said a few things about the well-being economy and outcomes measures and how we measure economic growth. So I guess that fits in the community wealth building. And then also some of the stuff about the environment, which fits in with the kind of presentation we heard. Okay, before we move on to the second point, is there anything?
Can I just follow up on that? I think it was more around, I think it's great when innovation, and I like that Leon's on the panel about design, because I think some of that redesign and reimagining of our spaces is really important in anything we talk about in wellbeing. I know some of what Rebecca was saying earlier is really relevant, but I think certainly when you're in a research space or health delivery space, I'm talking about radical, no one says stop doing something. What they do is just bolt on other things around innovation without actually considering what we don't need to be doing. So I think it just becomes a sort of a vicious circle of we need to innovate, we need to create, we need to be sort of experimental, and that's fabulous, but nothing ever drops off. So I think that, you know, when we're saying be brave, be radical, maybe it's about reimagining something where we can stop doing some stuff. And I know there's quite a lot of constraints often around that, but I know Matthew was talking earlier about ways around stuff, whether that be policy, whether that be legislation. So I think thinking more creatively about what we can do within the confines of the sort of resource envelope we've got, whether that be people, community, money. I think that's really helpful to think about. And then thinking about, when I was talking about growth, other types of growth, not just economic growth, because as you just referred to, Andy, it's not just about the pounds. You know, you've reflected on people with mental health, well-being conditions. You know, it's not just being a poverty issue, it's about other things that we need to consider. So I think we need to throw everything in the bag and think about what's the next steps are and what's best.
Excellent, thanks. I see, Leon, you want to come back to that.
Yeah, Paul, I completely agree with you. I should have said so I'm a designer, but I don't design stuff. I design new types of interaction between communities and between the public sector. So it's about bringing people together to stuff, but there absolutely is a tendency to evaluate maybe, but those evaluations don't result in much change. You know, so what isn't working should be thought through and maybe not done anymore. But rather, so I was just agreeing with you that it isn't about just bolting on something new and shiny. That was my argument, was the exact opposite of that. I hope that we should be more fundamental in our thinking about how we can change things and involve communities as part of that active dialogue. That would be that's my research interest.
Matthew, did you want to come in on that?
Yeah, just really briefly. I mean, these are two really excellent questions. I mean, I think what I've struggled with as a politician is how local government has been systemically under-resourced for decades, and the powers that we have are not there anymore. If you go back to when I was a lad in the 70s or 80s, local councils were the largest builder of housing. They ran and owned buses. You know, we've lost a lot of that democracy. So I think what we need to do to actually support better health and better economies is try to get some of that democracy back. And this is why in Preston, we're looking to work with churches to establish community land trusts. We're looking at setting up our own cooperative bank, because the current banking system is actually not lending to some communities and local businesses in those communities. You know, we're looking for the council to establish a broadband company to provide free broadband to get people online to deal with digital exclusion. So we need to bring that democracy back, and it can be done now. And it just needs a bit of creativity and thinking outside the box. I mean, for example, there's some fantastic American examples. There was talk about the internet and the power of the internet. I mean, I think in Denver, Colorado, you've had trade unions who've worked to basically put taxi drivers in a worker cooperative, which now has about 4,000 members, because what we see as part of the gig economy is how it exploits minority communities often through the likes of Uber and the rest of it, and how we can potentially look to working communities to actually have more democratic alternatives that communities own and actually can deal with taking control of their economic lives. And by doing that, they then often have better working conditions and can actually have better public health as well. So I do think we need to think outside the box and have a little more creativity, because, you know, I mean, it really is a very unequal country, the UK. We've gone from, in the late 70s, being the most, or one of the most equal in Europe, to now probably the most unequal. And when you do that, you have severe ramifications for society, whether it's poverty, mental health, ill health, or even crime and antisocial behaviour that comes from that. So I think there's a lot of things we can do now, but I just think we've got to really reimagine how we do things and do things very differently.
Thanks. So that is a good segue in then to the second question to put to the panel. So what is the biggest barrier to implementing effective place-based approaches, and what innovative solutions can we co-create to overcome it? So I know, Matthew, you've said a lot about kind of community bus and housing. Is there anything else that you wanted to add?
Very interestingly, the NHS trusts across the country, or many of them are actually forming anchor institutions. So as I said earlier, I think in terms of looking at how we can get all the public sector together in one area and look at how we can combine procurement budgets, recruitment, supporting a positive economy, looking at land and assets to support community organisations, you know, provide more renewable energy that's cheap for residents and the rest of it, and, you know, supporting new social and affordable housing. I think that collaboration is what's needed, and the NHS are leading in many places on looking at that collaboration. I do think it needs to be a little more transformative just due to the inequalities we face, but I think a lot of it's happening now.
Thank you. Leon?
I think I've said. I think I've said enough for this one. Thank you.
Okay. Alan?
To be honest, I didn't quite catch the question, but I used to work in urban regeneration and for Knowsley Council, which at the time was the second poorest borough in England, if not in the UK, and did an awful lot of work trying to improve housing estates and to some extent the houses themselves. And we had quite a lot of really good results. For example, crime levels went down, more people, school attainments went up, all sorts of things that you would hope to achieve. Unfortunately, one thing we didn't do, this was done in the 90s and the noughties, but one thing we didn't do was take health into consideration. I really, really, really wish now that we had, because I'd love to know, because here we are sort of 20 odd years further on, if not 30 odd years further on, what effect we would have had on the health of the people and life expectancy and all that sort of stuff. So big regret that we didn't do that. Sorry if that goes nowhere whatsoever towards answering your question, but I suppose I'm saying it because I think that sort of work that we did then is the sort of thing that would really help a lot of the towns and boroughs around the northwest, if not around the whole country. But it's very expensive.
Yeah, no, thank you. No, that does help. Andy, did you have something you wanted to add?
Yeah, I'm not sure it's the biggest barrier, but I would say that something we need to be aware of is that I think we're in danger of sleepwalking into an age of urban decline in centres because of because we're living, working, playing, shopping remotely, and we can see these forces have had a big impact on lots of town centres and the people that live, workshop, etc. in them. So I think we're behind the curve on that, and that we need to repurpose these places for modern uses. We need to adapt them for housing and other uses, and try and build community back in rather than just watching idly by as they degenerate.
Thanks. Ben?
Thanks, Heather. Yeah, I mean, in terms of kind of barriers and limitations, I guess, there is a lot that local agencies and communities can do, and we've heard about some really innovative kind of approaches. But there's always going to be limitations to how much you can address these, ingrained inequalities just through those kind of local actions. As Matthew said, we are one of the most unequal countries in Europe, particularly geographically unequal. And without national policy and national government putting in place actions to kind of support major change, it's always going to be fairly limited what we can do locally. I mean, the current government, their one big focus apparently is on economic growth and their growth mission. But there's very little in that strategy that says how that growth is going to benefit places like Preston, or address these inequalities, or look at how that growth is going to promote health. So and then at the same time we've got 5 billion being taken out of local economies, or out of the incomes of people with health problems and disabilities, which is potentially going to make some of these things worse. So I guess that devolving some of that to making to local places, but we need to also be trying to change national policy to try and create an environment where these kind of actions can make a difference to these inequalities.
Thanks. So would you say that some of that is then linking some of these things to economic growth?
I think so. I think there's quite a big argument that could be made around current growth strategies. For example, you know, that's one route to potentially address, you know, the levels of inactivity and rising inactivity amongst people with health problems. You know, we've saw from the work in Preston that, you know, you can produce economic growth that actually addresses that problem. At the moment, that's not it's not mentioned or thought of in the government's growth strategy. Although, you know, it is a concern for government that, you know, the rising sort of welfare bill around disability benefits. So, you know, joining up those things within kind of central government policy would also, you know, have huge benefits.
Excellent, thank you. So, Kristof, did you have anything to add?
Yes, just a bit. In relation to the barrier, I would say it's based on what we have discovered would be lack of central infrastructure coordination for the VCFSE sector. Obviously, that is in Blackpool and Fife Coast because that's where the research was conducted. Because, as I mentioned as well, we found a lot of organizations collaborating only within their own service domains. So there is no reach, or there is lack of reach towards other type of sectors. And that relates to what others have mentioned as well, Ben, Matthew, and previously, that this research was good for exploring what's out there. And it's not about creating something new. It's not about this continuous cycle of creation. It's looking back what we have and then see what can we do with that. And of course, that is easier said than done because in this changing socio-political sphere of 2025, it is a constantly changing climate. So this could be a method of bringing everyone together. But again, there are these changing spheres in the equation. Yeah, that's all from me. Thank you.
Excellent. Thanks, everyone. Just see if there's anything else in the chat. Yeah, so Hilary has just mentioned redesigning and reimagining how we approach inequalities, the questions we ask, how we ask them, and the way we develop intervention process and relationships. So being flexible and creative. So that kind of falls on for some of the things that Paula, you said earlier about outcomes. And then moving on to the final question is, how can we ensure community voices are central to designing and sustaining place-based initiatives, and what resources or support do communities need most from us? So I'll start with you, Matthew. Do you have?
Sorry, could you just repeat that again, please?
Of course. So how can we ensure community voices are central to designing and sustaining place-based initiatives? And what resources or support do community needs most from us?
It's a very, very good question. Not an easy one, but it's an excellent question nonetheless. I just think in our institutions, we've got to find a way of ensuring communities are positively engaged in everything we do. I think that's a very important thing. But I do think there's probably a role to look at how we can potentially look at things like participatory budgeting, especially at a council level, or some kind of more direct engagement where we actually go into communities and we can potentially bring other organisations there, such as public health and the NHS, and just say, you know, these are the issues in your area, this is the plan that we do have, and give communities a way to actually have more ownership and control of that process. Because I think that lack of agency and that lack of democracy sometimes in our institutions is a real problem. So I think, you know, finding ways to have some kind of like public forums where we bring all these partners together and talk about issues like health inequalities and public health more generally, and how we can tackle it alongside the council and others. I think that's the way we've got to go, because I just think there's sometimes a feeling that many institutions like your local council or the NHS or others, they're too remote, and that even though as brilliant as they are, there's not that direct psychological buy-in from communities, because you don't feel they're actually making a difference in what happens. So I think some new way of looking at how we can actually engage in some kind of citizens forums, I think, is a good way to do things. That's just a thought I had. I might be completely wrong, but it's just the first thing that came into my head. Thanks.
No, That's great. And I think that leads nicely onto you, Leon.
Yes, I am. So that's Matthew, more or less all I do is try and engender those conversations and those dialogues. And I'm writing a book called We Don't Have Time for Shortcuts, about how real co-production takes time. It can be incredibly effective and very, very good value for many. But a lot of it is done in a tokenistic way, in a way that there isn't a kind of joint entering into an adventure together between the people in power and the people who are done to. And it's really very easy for very intelligent, effective people to be paternalistic in their engagement with communities, and you don't end up with a good dialogue, so you don't end up with anything surprising. So one of my sort of touchstones when I'm working with professionals working with communities is, how are you changing what you're doing? How are you changing, and how have you been changed by what you've been doing? And that's for citizens as well as professionals. So having that, building that space where you can have a real dialogue and people can play to their strengths in that space that's the pathway to real change. And citizen assemblies and participatory budgeting can help with that. Also, though, that it is possible to I suppose bottom down is as bad as top up. Top down is as bad as bottom up. It's got to be a kind of coming together and people playing to their strengths. So that takes quite a bit of nuance to develop those relationships where you are not setting a community member up with a responsibility that really, why would they be good at that? It's a complicated picture, but it needs people to really properly work together. And health is not known for its well, it is known for a little bit of hierarchy, and getting people to step away from that hierarchy and those power dynamics that they're used to living in, and working with communities on an equal basis is a really good starting point for doing meaningful things.
Excellent, thank you, Leon. And there's lots of comments for you in the chat, so do have a look. Alan, over to you.
Yeah, somebody's put in the chat as well that consultation isn't enough. More time and money needs to be spent on true co-production. I couldn't agree more with that. Councillor Matthew, please don't take this the wrong way. I spent my whole career in local government, but there is a habit in local government that the senior officers and the councillors will make the decisions and then actually go consult the people about what they've decided already, and it's the wrong way round. It needs to be done the other way round. Talk to the people with a completely open book and say, right, what's wrong? What would you like us to do? And to me, that's the way forward. But sadly, it's not the way we tend to do it. We could call it co-production, but it isn't really co-production.
Thanks.
Sorry, Matthew. I hope I didn't upset you by saying that. But
Andy, did you have something you wanted to add to that?
Yeah. So sorry, I had to answer the door, so maybe I missed part of it. But I heard Leon's and Alan's. I think I got the gist of them. I spent 10+ years researching the evidence base on community engagement, involvement, joint decision making, etc. We did with What Works Centre for Wellbeing, we did a scoping review looking at the evidence, and then we did a systematic review with Margaret Whitehead. I did a critical review of theory and some other reviews of evidence as well. And it's quite surprising because I'll give you an example. So there was a big systematic review that a well-known body, I won't mention them, that included 300 studies that were supposed to be about community involvement. And I went through them one by one, and I could only identify 3 out of 300 were people that had actually been meaningfully engaged, where it wasn't tokenism. So then I went away and I looked for hard to find evidence, and I managed to pull together 29 examples where they'd at least attempted to meaningfully engage people. And actually, if you get it wrong, it can be bad for people. So we need to remember that when we're looking at these interventions. Obviously, if you get it right, there's lots of benefits. But you know, we went back to the Arnstein's ladder of community civil engagement or participation, which I think is still really, really useful, even though it's more than 50 years later, because often what we're getting is the kind of tokenism, and what we need is proper empowerment, etc. as well. So anyway, too long a point as usual. I've put an evidence link to an evidence briefing that we did based on the scoping review and the systematic review as well. So the point was that there's evidence when you take a step back and look across the body of evidence to support those points that you are making.
Great, excellent, thank you, Andy. Dorcas?
Thank you so much, Edda. What I just wanted to mention is that even before we go to the communities, we need to find out who are those communities, where are they, how do we reach them? Because there is no point in saying communities in a city that Liverpool is so diverse. How can I reach them? You know, either local government or NHS. And that is my question. And somebody's mentioned about empowering them. That's another thing. That people, before you come to us, we always say, well, they're just asking a question. We won't get the feedback. That's another thing the communities complain about. We don't get feedback. But if you want to work with them, you need to find out first, what do they need? That's what I've done in the past as a midwife. Find out first, what do they need? If you go to them first and they think, oh yes, our pack, we need to do this, they will join. They themselves will be empowered to say, yes, we do something with this area. And that is how I think people should work. But if you don't go to them and find out, and you think, oh, I know what they need, I go to them, it does not work. And I'm sure a lot of them want to collaborate. They want to work together with the power to be. And somebody said, as Alan said, you know, the councillor will go to you. If it's the staff that needs to go to them, let them go to them. And it's important, really, that we work with communities. If we want to make a change, if we want to make a difference, either in research, when you do your research, make sure you go back to say, this is the outcome of the research, and this is what is going to happen. But we tend to find out that we're like a tick box exercise, you know. So as a public advisor now, I tend to encourage our community to say, you know, if you don't say your voice, don't complain tomorrow. You know, that's another thing I tend to tell them. They want to hear from us. Let's say what we need. I just want to say, know your communities, go to them, and then find out what they need, and through that, collaboration, designing will follow up. Thank you so much.
Thank you, Dorcas. Kristof, did you have anything you wanted to add?
I have nothing else to add. Thank you.
Okay, great. Thank you. So I'm just conscious of time and the fact that we've been here since 10, and well, at least I'm very hungry. So should we kind of wrap up, unless anyone on the panel, do you have any final thoughts, comments? No. Great. Well, thank you, everyone. And Mark, did you have any concluding comments that you wanted to make?
Sorry, just struggling to get to the right buttons. Yes, I would please, if that's all right. I can get my camera to work. So thank you very much, everybody, for attending. It's been a really interesting morning. I hope you all agree. Place-based research is important, interesting, and very relevant for communities across our region. And the findings of our work are very important nationally. And we are doing some really important and interesting work in that, as I hope you've found out this morning. I hope the panelists were able to answer your questions, but please do get in touch if you have any other questions or if you'd like to get involved with any of the work that you've heard about today. please do go and look on our website and find out what we're doing. I would also repeat my plea to our member organisation staff who are here with us today. We really do need the evidence of your impact, please, because I will be asked a lot about that when I'm presenting the ARC2 proposal on the 22nd of July, I think it is, in London. So please do let us have information about how our work has made a difference in your organisation, and we will be back in touch to get a few more details from you. Many thanks indeed for your time. I hope you found today has been worthwhile and interesting, and I look forward to seeing you at the next virtual ARCFEST, which we're planning for September.